Oh, good afternoon. We're going to get started since we have a full agenda this afternoon. Thank you, everybody. Welcome to PCCSM Focus Clinical Updates for 2024. We have 4 speakers today, and I will show you, these are the 4 speakers who I'm going to introduce, and this is the disclosure along with the CME code for all of you who want your CME. I'm not going to do lengthy introductions. They are all wonderful speakers. But I'll tell you who they are and a little about them for those of you who don't know them. First will be Dr. Rachel Beekman, who's in the Department of Neurology, specifically in neurocritical care. A lot of you know her. She has a lot of expertise in brain death and neurologic injury, and it's been tremendously helpful both to the MICU and the ICUs throughout the whole system in terms of her expertise in this area. So welcome. I am the second speaker. Third is Dr. Brian Clark, who is assistant professor in pulmonary critical care. He has interest in asthma and is the associate program director for our pulmonary critical care fellowship. And he also leads the level 1 CPAP, among other interests. And he'll be talking about some issues related to PFT testing. And last is Dr. Denyse Lutchmansingh, who's associate director for Winchester Center for Lung Disease. And was one of the leaders for the post-COVID clinic, which is transitioning into a post-ICU clinic, which we're very excited about. And she's going to update us a little on the literature and then what she is working on, so we all know. So with that, we'll start with Dr. Beekman.
Hi, everyone. Thank you so much for having me today. So I'm going to give you an update about brain death. So as we all know, brain death is the permanent loss of functions of the entire brain, including the brain stem. And there was a major update to the guidelines in about November 2023. This guideline came out supported by the American Academy of Neurology, the American Academy of Pediatrics, the Child Neurologic Society, and the Society of Critical Care Medicine. And so we're going to go through some of the updates and how that pertains to your clinical practice. So the 2 main components of brain death are permanency and then coma, brainstem areflexia, and apnea. It is critical, though, that condition 1 is met before proceeding to condition 2. So you will see patients who have coma, brainstem areflexia, and apnea who are not brain dead. Permanency is a term that was actually changed in the new guidelines. It used to be irreversibility. And the reason it was changed is because permanency is felt to reflect both a loss of function that cannot resume spontaneously and that will not be restored. And this specific change in language is because there have been many advances in science. I'm sure some of you have heard of BrainX and other things that are recovering deceased cells. And the permanency is meant that we are not going to restore the activity. It is vital that we understand what the etiology of brain injury is, and that etiology of brain injury is consistent with causing whole brain death. So that is the #1 prerequisite that needs to be met. And then you must exclude any confounding condition that can mimic brain death. And I'm not going to read you the list here, but you can see the most common confounding conditions that we need to rule out. So I'm going to start with 2 cases just to highlight why these guidelines are important. The first case is a 58-year-old male who has atrial fibrillation on anticoagulation, also with hypertension. And he presented as a bicycle versus motor vehicle collision. On the scene, his GCS is 3. He has on imaging, I'm just going to show on the next slide, a right frontal intraparenchymal hemorrhage. There is intraventricular hemorrhage. Sorry, it is coming. There is effacement of the cistern, cerebral edema, and this is concerning for very severe brain injury. He is taken emergently for a craniotomy. And luckily, post-operatively, his GCS improves to 14. He has some mild confusion. He is eventually transferred out to the floor, but on post-trauma day 9, he transfers back to the neuro ICU in the setting of hypercarbic respiratory failure, requiring emergent intubation. Shortly after intubation, his mental status does improve enough that he's following some basic commands, and at that point, he is extubated. But after a prolonged period of apnea, he's emergently reintubated. Subsequent to that reintubation, he's not moving his arms or his legs. A C-spine MRI is done, which shows no evidence of spinal cord injury. but he continues to have neurologic worsening and develops brainstem areflexia. This is the repeat imaging at the time of neurologic decline, and your neuroradiology report says evolving brain injury. So on your evaluation, he's normothermic, normotensive. He is breathing at the set rate of the ventilator. There's no eye opening, no blink to threat, no corneal, no cough, no gag. His pupils are 6 millimeters and non-reactive, and that's confirmed by a pupillometer with an NPI of 0. He has no motor movement to noxious in all 4 limbs. So just a poll of hands, who thinks that we can proceed with brain death testing? Excellent. So this case highlights, number 1, permanency. So that head CT is inconsistent with whole brain death, and alternative diagnoses then need to be evaluated. This patient was subsequently identified to have acute motor and sensory axonal neuropathy, which is a variant of Guillain-Barré. Was treated with IVIG, and at 2 years was independent in all ADLs. So there are neurologic diseases that can mimic brain death. I'm gonna move on to case 2, which is a 52-year-old female with no past medical history. She presents with worst headache of life while shopping. In the ED, her GCS was initially a 12, but rapidly declined to a GCS of 3. She required emergent intubation. She was treated with hyperosmolar therapy, but had no improvement in her examination. I'm gonna show you her head CT, which you can already see there's blood in the foramen magnum. And as we come up, there's blood in the cerebellar vermis. I don't know, you can see my pointer. There's blood in the ventricles, early hydrocephalus. So on her exam, she's normothermic. She's a little bit hypertensive and bradycardic. She's breathing at the set rate of the ventilator, similar to our prior patient. Complete brainstem areflexia, no neurologic response on examination. In terms of sedation, fentanyl was given 30 minutes prior, and succinylcholine was used an hour prior for intubation. So same question, can we proceed with brain death testing? I'm seeing no's. So there's a few things to pick up from this patient. So the first is that pinpoint pupils point to either confounding by toxins or brainstem death, which we do not declare in the United States. We must meet criteria for whole brain death. The other is, this is an update to the guidelines. For posterior fossa injuries, you need to ensure that whole brain death occurred. And that usually happens by development of obstructive hydrocephalus, raised intracranial pressure, decreased cerebral perfusion, and then whole brain ischemia. And that does take time after the posterior fossa injury. So this patient may progress to brain death over time, but the trigger to evaluate with repeat imaging should be then fixed and dilated pupils. So pupils should be 4 millimeters or larger in patients who have brain death. And there is a new requirement on the guidelines that you must see whole brain injury on imaging to proceed with testing. As with any other patient, if there was recent paralysis, you should do a train of 4 to rule out ongoing paralysis, and then you need 5 half-lives of clearance of a sedative. And that's going to really depend on the age, the hepatic function, the length of use. So prolonged use of sedatives will result in a longer half-life, and you should touch base with your pharmacist for this. I'm going to mention this because there's a huge increase in drug overdose, cardiac arrest, and cardiac arrest is a very large reason that patients progress to brain death. You can't rely on the UTOX because just because there's positive of any substance in the UTOX, that doesn't mean that it's active anymore. So you want to focus more on the half-life of that drug rather than the positivity in the urine. In terms of specific requirements, we really did focus on 1 and 2 with those cases. The other big changes are that if a patient is hypothermic, that you need 24 hours of normothermia. And so once 36 is achieved, you need to maintain 36 for 24 hours prior to proceeding with testing. Other changes include that the blood pressure requirements are higher. So mean arterial pressure must be greater than or equal to 75 and a systolic greater than 100 to proceed with testing. It is really important, and this is really highlighted in the guidelines, that ancillary tests are not used in lieu of appropriate clinical testing and cannot be used in the setting of hypothermia, sedating medications, because it is important to correct those variables, wait the allotted time, repeat your clinical examination, and ancillary testing is only required in certain circumstances, which we'll get into. In terms of apnea testing, they have highlighted that apnea is a key component, right? We went over on that first slide, permanency, coma, brainstem areflexia, and apnea. And so apnea testing is required to be tested in all patients if they're able to proceed with testing. There's a change in the test positivity. And so it's not just a PaCO2 greater than 60, but you also have to achieve 20 above your baseline and a acidemia with a pH less than 7.3. In cases with chronic CO2 retention, you want their pre-apnea baseline to be what their normal CO2 is for them. But if you know that they're a chronic CO2 retainer and you don't know what their baseline is, in addition to completing an apnea test and meeting these criteria, you also need to do an ancillary test. And that's to make sure that you have had an appropriate rise in CO2. In terms of ancillary testing, the main change is that EEG is removed from the list of acceptable tests. It does not provide any information about brainstem function and can be misleading. These are the 3 acceptable tests, DSA, nuclear medicine tests, and TCD. I do want to highlight, we use nuclear medicine flow studies most commonly. We don't actually do SPECT. SPECT is done and can be sent, patients can be sent back for SPECT in circumstances where the brainstem is not well visualized. But that means that our sensitivity and specificity are slightly lower than this. And an ancillary test cannot be used in lieu of everything else. The positivity of an ancillary test is confirming your clinical diagnosis, but your clinical diagnosis must come first. In terms of clinical pearls for apnea testing, patients with catastrophic brain injury have multifactorial hypotension. When the brain herniates, you lose the hypothalamic pituitary axis. So T4 protocol can be very helpful in stabilizing patients. You want to recognize diabetes insipidus early and treat with vasopressin and make sure they're euvolemic prior to apnea testing. And just recognize that during apnea testing, patients are getting hypercarbic. That's the goal. They will become vasoplegic. So titrate pressors above your goal so that you don't have to abort testing. It is important to pre-oxygenate, and you must achieve a PaO2 greater than 200. And you can do so using a flow insufflating bag with a PEEP valve. We've done this in many patients, even on a PEEP of 16 or 18, and it works very well. That can be ordered through the catastrophic brain injury pathway, and you just click these blue sections to choose what you would like. In terms of documentation, super important that documentation is standardized because this is clinical death. And so we have templates to do that. We have notes here where you can enter a smart text and get the determination of death note, or you can put in brain death, and it will guide you through to make sure that you document each component of the brain death evaluation. It's also really important that the time of death on the death certificate is consistent with the time of death in your note, because that is the time of death. It's not the time that the heart stops. Lastly, just some tips and tricks for discussing brain death. This is really hard and it's challenging for everyone involved, including the family. Brain death is a clinical diagnosis, and it's our obligation to proceed with testing when patients meet criteria. Consent from the family is not required. It is really important, though, to inform the family that neurologic evaluation for neurologic death is taking place prior, and to give them an opportunity to observe testing. And this can be very helpful for families who may not understand the diagnosis, but they will when they see how thorough the exam is. I always communicate prior to my testing that I expect that the results of my testing will be confirmatory, and that means when we talk next, I will be giving you time of death. I think it's very helpful to give them a framework and time to understand while waiting for next steps, and often makes the delivery of time of death much easier for your teams. Lastly, while family permission is not required to remove the ventilator, we often give a reasonable amount of time for family visitation. One thing that's really important during this time period is that we don't mention organ donation. We have to be separate from that process, but you do want to convene with New England Donor Services prior to brain death and then prior to the notifying the family so that you can be on the same team. And you want to be somewhat vague about terms in terms of next steps, because the next steps will depend on whether they are an organ donor or not. And so you just want to introduce that there are other teams that are available at the end of life, and that the next steps can be discussed after you've met with those teams to really provide time without kind of binding yourself into a specific timeline that will end up getting changed. And I know that was a lot of information, a quick highlight of the updates, and I'm happy to take any questions.
Well, just a question about the clinical time of death. A question about the clinical time of death, like how do we pick that point?
So really good question. So that's actually highlighted in the policy and in the guidelines. So if you do a clinical test plus an apnea test, it's the time that the first blood gas consistent with brain death, so meeting those criteria, returns from the lab. So not the time you sent it, but the time it results in the EMR. If you have to use an ancillary test, then it is the time that the ancillary test is read by the attending, and that's the time that it's recorded in Epic. So not the time you're called, but the time that it's in Epic. And this has been outlined by the guidelines so that we all standardize and use the exact same language when we're talking about time of death. Yeah.
I know in the past iterations of policies and guidelines that there have been different recommendations on who should be doing these evaluations and specifically the training of the people who are doing those evaluations. So where do things stand now? So
the updated guidelines actually do, for the first time, discuss competency and how to maintain competency. We are working on a process to ensure that that at least at this campus, we have the neuro ICU team to help. We're working on a process to make sure that there's neuro expertise across the system as well. And we're also working internally within the neurology department to make sure that we have a pathway for competency.
So what that's like we need.
So here you'll always involve the NICU.
Yeah, just a comment. We had sent out an email, which maybe you're referencing. So the issue is that we want the involvement of your ICU leadership along with the neurocritical care because it's complicated. And so that this process is supported when you're considering brain death. It's not like when you're all the way at the end, you call and say, what do we do now? If you're considering testing, communicating with the family, that's when because that's where you can get off both to the wrong foot with both the testing, if you choose the wrong process or just the communication. And so NeuroIC here has been very helpful, but it's still good to have everybody aware. Thank you very much, Rachel. Brian. Do that one.
Yeah, either one works. All right. Hi, everyone. So Jonathan asked me to talk about bronchoprovocation testing, which I really like because it made me actually go through everything and will guide everything I choose. So let's just talk. I'm going to use bronchial challenge and bronchoprovocation interchangeably throughout the talk. Whichever one jumps into my mind is the one I'm going to say. And so it's used to assess airway hyperresponsiveness, defined as increased sensitivity and exaggerated response to non-allergic stimuli to cause airway narrowing. So I think we should use it in any symptoms where symptoms are suggestive of asthma, but spirometry is inconclusive. Symptoms are possibly consistent with asthma. If they're atypical symptoms, an atypical or unexpected response to therapy, or airway hyperresponsiveness would pose a high safety risk. So if someone's a commercial diver, they're going to go down in a submarine, and we really need to try to disprove asthma. I think, I will add that if we just clinically feel very strongly that it's asthma, we should still force ourselves to confirm it. And so I actually think that our clinical gestalt is where everything starts right here. So this is ERS's guidelines for the diagnosis of asthma and every different way we can prove it. So we do spirometry. We look for a bronchodilator response. Even though the PFT interpretation guideline have changed, the asthma guidelines haven't quite caught up, but I think either is probably fine to confirm the diagnosis. High FeNO, so not just our 25 or our 30, but really greater than 50 can help you confirm it. People can actually do peak expiratory flow variability, which is not something we do clinically very often here, but if we can't get it on all these steps, then we should proceed to bronchial challenge. And honestly, this is the place where we actually start seeing patients fairly frequently. And so we should be thinking about this a lot. So thinking about contraindications. So basically any situation in which the testing would be unsafe. So if someone starts with fairly significant baseline obstruction, they may not be able to tolerate worsening obstruction. If they just can't do good testing, then you're not going to get good results. So recent MI or stroke, so in the past 3 months, really bad uncontrolled hypertension. You can see numbers are pretty high, systolic greater than 200, diastolic greater than 100. Any recent eye surgery or elevated intracranial pressure risk. In general, like if they can't do exercise, if they can't do the testing for some other reason than just they can't perform the right spirometry, obviously the test isn't going to be valid. And so I'm going to focus entirely on methacholine and mannitol because those are the two main ones we do here. So just preparation for methacholine. Methacholine requires a little bit of less preparation. You have to hold bronchodilators basically. So your short-acting beta agonist, essentially day of, 6 hours before. Long-acting beta agonist, 36 hours before. Ultra long-acting beta agonist. So any of the once daily medications, those actually need to be held for 2 days. So your Brios, your Stialtos, things like that. Ipratropium, 12 hours, and then your LAMAs actually a week. So think about that before testing. Theophylline, which we don't use that frequently anymore, needs to be held for about a day. Other things to think about, and this isn't specifically stated in the guidelines, is that if you are on a drug that's suppressing the process that would lead to asthma or bronchospasm, think about a long hold. And so like if we're thinking about like someone has purely inflammatory asthma and it's all suppressed by their inhaled steroid, you have to hold that for up to 2 to 4 weeks beforehand to let the inflammatory process come out. So for mannitol, and we'll get into this on the next slide, depends a lot more on underlying inflammation. So it's a lot more sensitive to anti-inflammatory medication. So in addition to the beta agonist, all kinds of different anti-inflammatory medications. So your montelukast, antihistamines, your inhaled steroids, it says for a day, but again, same thing where you want to let the underlying process really come back out before you undertake the testing. And so that has an impact on the test characteristics. And so the way methacholine, it's a muscarinic agonist. It acts directly on the receptor in the smooth muscle and directly causes bronchospasm. It's more sensitive. It's less specific. It can be positive in normal patients. There's also stuff that has to do with the airway structure of COPD patients, where it can be positive in COPD patients without confirming or pointing more towards asthma. The other thing, I'm just going to talk about this a lot of times, the symptoms really need to be current though. So someone has all of their asthma symptoms in the spring, don't get methacholine in the fall because they just may not have it at that time. So really, really doing it when there's current symptoms is really important. So with mannitol, it's indirect. So mannitol, exercise, hypertonic saline, they're all indirect challenges. And what they do is they increase the osmolarity of the airway surface, trigger release of mediators from inflammatory cells, more so mast cells, but EOs also play a role. Closer correlation with airway inflammation. They both correlate with airway inflammation. Mannitol is a bit tighter in terms of correlation with sputum EOs and elevated FeNO. It's more specific. It's more easily suppressed by inhaled steroids. And there is a association with exercise-induced bronchoconstriction, but it's neither 100% sensitive nor specific. And sort of just looking pathway-wise how these work, I really like this slide. And so your hypertonic aerosols come in here. So they increase that osmolarity of the airway surface liquid, act on the epithelium and submucosa to increase cellular inflammation, cause inflammatory mediator release, and cause bronchial smooth muscle sensitivity. Down here is where methacholine is going to act. So you can see why methacholine is a bit more sensitive. And then you see bronchial smooth muscle contraction and airway narrowing. So how we do our procedure here. And so so for both of them, we perform baseline spirometry. Methacholine, we do 6 tidal breaths, the 6 tidal breath method. Tidal breathing is actually better than the methods that involve TLC because actually inhaling to TLC can suppress bronchospasm. So that's why we start with tidal breathing, and we start with a diluent, mostly just to get the patient used to the procedure, and then proceed with quadrupling doses of methacholine. There's some places do doubling, some places do quadrupling. Quadrupling is as effective, and it cuts down on the time and effort for patient and testing. You stop the test or the test is positive if there's a 20% fall in FEV1 or you reach the max dose. So mannitol, same thing, baseline spirometry. It's a dry powder, so there's no diluent, and this proceeds with doubling doses. You stop the test if there's a 15% fall in FEV1. So remember that. With methacholine, it's a 20% fall. With mannitol, it's a 15% fall or a 10% fall between doses, and you proceed until you reach a dose of 635 milligrams. And so interpreting your methacholine test. So historically, it was provocative concentration. Now it's moved to provocative dose. The reason it was originally concentration is they were specified you could use 2 specific nebulizers or dosimeters, and the concentration through those machines was intended to deliver a specific dose. Now those machines, one of those machines is off the market, and there are a lot of better machines that can measure dose more specifically, and doing dose instead of concentration just allows you to use a wider number of devices. So it's PD20, and we express in our lab the value in micrograms, so the ones in parentheses here. So marked airway hyperresponsiveness, if you have a PD20 of less than 6, mild, moderate 6 to 25, mild 25 to 100, borderline 100 to 400, and negative if it's greater than 400. And so not surprisingly, your post-test probability of asthma is dependent on both your pre-test probability of asthma and the dose to which you respond. And you can see the lower dose you respond, the higher probability you have of having asthma. And so looking at one of our tests here, we can see, and now you'll see in Epic, or in Compass rather, our tests look like this now. This is going to be different than what they looked like even a month ago. And the way you can tell the new one is the graph is going to be on the bottom like this, with the table being on the top. And so you see the dosage the patient was delivered, you see their FVC, their FEV1, and their peak expiratory flow, as well as their FEF 25, 75. And then you have the graph and you see the point at which they fall 20%. Here you can see, and the dose, the PD20 is actually extrapolated based upon what their FEV1 was before they got the dose and the dose at which they fell below that. And the machine will spit out an extrapolated PD20 and an auto interpretation here. So this one, the PD20 was 264, and it'll give you, it indicates borderline, as you can see right here, borderline airway hyperresponsiveness between 100 and 400. So just special asterisk here. If you see the one where the graph is on the top, the graph is wrong, and the auto-interp is wrong. And so if you look, it'll say dose in micrograms, but actually what's expressed here in numbers is PC20. So you're going to have to, if you want to interpret it based upon this graph, don't listen to what the auto-interp says. Go and look and understand you're looking at the PC20, and you can interpret based upon that PC20 that you see right back here. This is all in the ERS statement for direct challenge tests. This table comes from that. And so mannitol, you can see here is, so if you have a response, and that's, remember, PD15, a 15% fall or a 10% fall between doses of, at less than 35 milligrams, it's severe, 36 to 155 moderate, greater than 155 mild, and it's negative if you reach that 635 dose. And you can see the interpretation here. You can see the dose that's being given at the time, and the bottom here, or the second row, is the cumulative dose. That's the one we're actually looking at. And then you can see the point at which they fall below 15%. Here, the test I'm showing you is a negative test. And so just some conclusions. They're a really important tool in our kit. Honestly, once many asthma patients reach our clinic, they already have an indication for this testing. So we probably should be ordering it a lot more than we are. But sensitivity is really dependent on current symptoms and degree of inflammation. I didn't quote sensitivity because sensitivity and specificity for this testing was like all over the place. You read anywhere between like 60% and in the 90s. And I think a ton of that depends on the clinical scenario in which you're testing people. So use methacholine tests if you want to increase sensitivity. Use mannitol to increase specificity, or if you're really testing for EIB. But when in doubt, really just use methacholine. I think if you have one to stick with, methacholine is more sensitive. Most of the time we want a sensitive test. And so just remember, methacholine, it's a PD20, mannitol, it's a PD15. That's it.
Thank you, Brian. Any questions?
Very important to interpret testing, right? You showed very nicely this huge list of drugs that were effect. They have it listed for mannitol primarily, washout periods, I think for some of these are actually short. For example, the long-acting drug that you take once a day, washout really is 4 or 5 days. You really want to be clear it's washed out. There's also anti-inflammatory effect. So you really have to be careful about interpreting tests like your test of a borderline patient, right, that reacted very well after they got a a certain patient who maybe would drink a cup of coffee or have been on steroids until 2 weeks prior. That could actually. Second thing I want to say, there's no gold standard. Second thing is that most labs do not have both tests. We're very rare. That's because PD, largely multiple reasons for that. But we've decided to keep them both. So just repeat that.
Just repeat the 2 tests.
I can summarize too.
Our lab is very unusual in that it has 2 tests, both methacholine and mannitol. And so, I think you should decide on which one you want to use really and get used to that. It's about the same effort for the lab. There can be issues in supply that need to be interpreted as well, because that's why we had it. Yeah.
Now say it without a mic.
Wait, so just to summarize the first part of what Jeff said just interpret it in clinical context, make sure drugs are held, make sure they're inflamed, pick the test you like better, and probably stick with that one, but that one should be methacholine.
Is the lab routinely telling people to hold all this stuff? I don't think so, right? Like sometimes I'll see a message to the patient that says like, hold this stuff. Often I'll have told the patient, but then it gets scheduled like weeks out. So I don't know if we could make that part of our process.
Marjorie's right behind you. I'll tell you the process.
Hi, I'm right behind. So we are doing a little bit of a clinical improvement process where we're going to be providing you guys with a smart phrase that you can send with the patient home with their ABS. So that's communication number 1. Communication number 2 will be by the scheduler, that they're sending them a message. And then number 3 is my layer, which is I send them a message as well with it. So when they come and say they didn't get the message, we know that they were notified 3 times.
So belt, suspenders, and overalls, really this. So as much as you can notify people. Of note, cup of coffee is not necessarily a problem with methacholine, just with mannitol. So why to choose methacholine?
Thank you, Brian. That was wonderful. So I'm going to talk about a tool that is now available in the hospital called eCart and give you a little background about clinical deteriorations and why it's relevant. I think it's worth talking about because there's a lot more AI around than there was. And actually, there's not that much in a lot of what we do, but it's in some places. And so some of you may be seeing some of the radiology reads are supported by AI, but there hasn't been much in pulmonary and critical care yet. But this is going to impact us. And it's a good sort of introduction to thinking about how it's useful in a very practical way, because it mostly is just frothy stuff in news blurbs about AI doing this and that, writing your R01 for Naftali, right? So why are we talking about this? I think that the original discussion started about 2 or 3 years ago because there was a concern that there was excess mortality among inpatients at Yale New Haven Hospital. That is multifactorial, but it did lead to a discussion about whether we were taking as good care of our patients in certain scenarios as we could. There are over 4,000 ICU admissions per year across the health system from inpatients. There are a lot more, including the ED and from the OR, but from inpatients. And so that tells you the scope of what we're talking about. It's a large population that was not needing ICU care, and then sometimes during their hospital stay needed ICU care, and that's presumably because they were getting worse. The mortality for those folks is high. It's over 20%. And if you come in through the ED to the ICU, it's only just over 10%. So there's a big difference. And so that's not all just because of just the clinical care. It has to do with the diseases. But sort of in looking at this, there's been a lot of work historically on this. And I'll summarize all of it briefly because it's not highly relevant, but it's worth just knowing. There have been a lot of alerts to sort of alert people about clinical deteriorations. People who've been around for a while know the famous the Rothman brothers, their story about their mother who died after a hospital discharge. And then that was bought here and was kind of just rolled out without any preparation, no workflow, no data. And so what happened? We all know what happens. We're kind of all slow adopters, even though we don't want to admit it, and nobody adopted it on the physician side. There was some uptake on the nursing side, but without sort of obvious workflows or data. So then Epic, which is kind of taken over, has a lot of AI tools now. And so they came up with their own deterioration index. And that was then just unloaded onto the health system because everything in Epic is available without any data, like none. And it's available, and they were building workflows for it. And then we have experience with sepsis alerts, and they're absolutely terrible. We actually shut them off. I shut them off during the pandemic because everybody else, they weren't working, and everybody else had like other more important things to do at the moment. And so we don't have a sepsis alert for a lot of things now. And so that's that. But the bottom line is, like, anybody who does quality improvement, you need a workflow. You can't just like roll something out. And you need data. And so what happens if people don't go to ICUs? This is from a group at University of Chicago. And if you meet some threshold for risk and there's a delay in ICU transfer, there's an hourly increase. You've seen data sort of like this for delay in antibiotics. It's all the same, and none of it's surprising. Like, if somebody needs critical care and they don't get it, clearly their risk is going to go up. And obviously an hour or two is generally not the issue, but often people are out there for 6, 8, 10, 12, 24 hours. And that's a little different. Just historically, what does this landscape look like? Everybody is familiar with the Institute of Medicine, publication 2000, 2001 around patient safety. And so one of the responses was looking at failure to rescue on inpatients in a lot of health systems, and most at this point rolled out some form of response. There's a lot of data around it. It's not my specific area of expertise, but it is all over the place. And some of it is not indicating that they help a whole lot. That's a whole separate discussion, but that's sort of the landscape now. And certainly all the hospitals in this health system have some kind of response, but it's not just the response and the workflow. It's like, how do you identify those patients? And so most hospitals have RRT triggers. You've all seen these little lists, like call somebody if their respiratory rates are above 26. And then there are these available scores, Muse and News. A lot of them used in the UK and less so here. But most of the triggers actually are just nurses go in and say, this patient looks terrible and they're not getting better and I need some help. That's like about 50% of the RRT activations. And I mean, there's nothing wrong with that. But that may or may not be the right way to do it. The big issue actually from a data perspective is that RRT triggers are univariate. And so it takes a big deviation in your respiratory rate to confer higher risk. But if you have a low saturation, a high respiratory rate, and a fever and low blood pressure, it's pretty obvious. And you do that when you evaluate patients. What do you say? You say, they don't look good. What you're saying is there's multiple areas where this patient is not doing well. But from a trigger perspective, particularly for nurses or people with less experience, a univariate deviation has to be substantial before it triggers something. What you want is something that looks at the patient and all their derangements. And you can have a much lower threshold for an individual deviation. And that's what AI can contribute, because you sort of do it when you do assessments, but we tend to miss things because we're not, like, our brain gets drawn to certain abnormalities and misses other things. And so AI tools can really look at the complexity and then categorize in large populations and provide you something that you may not be seeing. So the group at University of Chicago has been working on this for 12 years. And they developed this thing called eCart, which is what we're talking about. And it's like been all over the place outside the ICU for the past couple months. It looks at 97 elements. We won't go through all of them, but your standard vital signs, demographics, all this other stuff. And every time there's new data, it recalculates the score. And this is the list, but it's mostly all ward patients excluding labor and delivery and pediatrics. And basically there's a huge learning set. And then they sort of basically it identifies subgroups, right? It's known to it in its special brain, and it confers risk to all of these, and it can calculate a risk based on the past groups. And so it's not just the implementation, it's not just the score, it's also they've developed a whole workflow, which we'll talk about in a second. But an intervention at a sort of a moderate sized health system showed a substantial decrease in hospital mortality using both the tool as well as a specific workflow. And they didn't test one versus the other, so I can't tell you which, but it was the whole implementation, which is important. It decreased time to ICU transfer, decreased mortality, increased vital signs reassessments, which is probably one of the key things this does. And it did increase ICU transfers, which people say, oh my God, the ICU can't take it. Well, maybe we want people who are going to come in earlier so we can fix them, right? You can't have it both ways. So it's going to do that. But the length of stay for the ICU patients did not go up because you're getting people sooner. So the issue was the data was there, but we wanted to know if it would work here. Because we've had 2 failed implementations with 2 other scores, and we wanted to know that would work here. So we did a retrospective analysis of 5 years, looked at all consecutive adult inpatients who were admitted, who could be scored, meaning they had enough vital sign data. And the data was, we have Rothman, which this health system had. We don't anymore because of this data. We had Epic DI, which is free. We back calculated news and Muse for the past 5 years on all those encounters. And then we back calculated ECART with help from the University of Chicago. And the primary outcome was clinical deterioration defined as ICU transfer or death within 24 hours following the score. And there's a lot of data, but I'm just going to go through a couple pieces here. Mostly comparative, but I think you'll see why we went with this when you look at the data. So I'll just go to the high threshold first hold. If you look at the high threshold, and remember these are preset cutoffs based on other training sets. Epic DI, which is what was being used by our SWAT and rapid response teams here, had only a 16% sensitivity at their higher threshold, but a 7% positive predictive value, which is not terrible for this kind of alert, okay? And so it says, okay, it's missing most of the patients, but at least if it goes off, it's helpful. That's not a great statement if you're missing 84% of the patients, but at least when the alert goes off, you should pay attention to it. ECART, on the other hand, is 46% sensitive. And that's better than it looks, because you have to remember that some deaths or ICU transfers are not predictable. Somebody has a massive MI. In theory, it's predictable, but we don't really have the tools for that. And that's not going to show up in anything. So 100% is not realistic. Positive predictive value there is 15%. You can see that News, which is free, outperforms Rothman and Epic DI. If you go to a slightly lower threshold, you see now that Epic DI is 86% sensitive. You say, that's great. We're not going to miss people. You know why you're not missing anybody? It's firing on everybody, even people who were technically not predictable, because it's firing on bad data. But then your positive predictive value is 1%. And that's why we shut it off. If you respond to 100 alerts with Epic DI, only 1% of those people are going to be in the ICU or dead in the next 24 hours. So you have to hire like 3 more RRTs to respond to that. And that's not feasible. ECART has a 11% positive predictive value and a 60% sensitivity. That's pretty good. You catch most of the patients, and if the alert goes off, you know that it actually means something. You should take a good look, which is what you really want. What does it look like in real life? This is a week's worth of data from both campuses showing the number of firings per unit. And you can see it's like 0, 1, or 2. Some of the places are higher because it's not designed for ICUs. They're mixed units. So just toss that out, like 3 West or 10-7. So that's it. It's whatever it is. It's like 37 alerts for a week, which for this size hospital is not that much. The SWAT nurses were getting push alerts every time DI crossed the threshold. They were like ready to throw it out the window because it was well north of 600 alerts for the whole week. Like nobody can do that. So Epic DI was just turned off here last week. So we're done with Rothman. Epic DI is gone. This is what it looks like in sort of, again, in real life. It shows up in the storyboard, and if you can add it as a column to your patient list. Again, we'll talk about what it means for the ICU, but you're all going to be evaluating floor patients, and that's why you sort of need to understand the context and how it works. In the patient chart, if you click on the storyboard, it shows you what it looks like. It shows you the last 72 hours, and it shows you the variables that are abnormal and how much they're contributing to the score. So if the score is elevated, you can go in there and say, eCart's giving them a high score because of their blood pressure, their respiratory rate, their saturation, their Braden scale, and their level of responsiveness. That's really important because now you know why, and then you can make your clinical decision about whether this is predictive in this patient, right? Which is what your job is. It's just telling you it has a concern. It's not telling you that something automatically is going to happen. And you can see at the bottom the nurse's chart on this. We'll come back to that. So the primary workflow is not for physicians. It alerts for the nurses. They see it when they're in there. And then they go into one of these pathways, just like we have pathways for physicians, and it gives them guidance about what to do. And they have multiple options. And there's also data about some of these options, like their level of concern. That's actually been studied, and that contributes to the pathway. You get RRT, et cetera. You don't need to go through all the pathways, but the point is it gives them some guidance, which is generally lacking in sort of these rollouts. And it's fairly detailed. All these things can be monitored. So the nurse goes in there, but there's no double documentation. The key piece is, and I talked about it, I think 2 years ago when I talked about preventing cardiac arrest in the ICU. We don't pay attention to the respiratory rate, not because it's not useful, it's because we don't pay attention to the respiratory rate. Of all the vital signs, it's probably the most predictive of how people are going to do, because you can't be tachypnic for a long time without there being a problem, and you can't, there's no mimicker of that for the most part. But we don't pay attention to the data because the data is bad. So one of the key things this year, get another vital signs, and the nurse is told to actually count the respiratory rate and then update it, and you get a new score. So it seems kind of silly, but it's not, because the respiratory rate is such a powerful predictor of how people are going to do. So how's this going to help? So there's the actual workflow, but the thing it really also provides us is some data and a window into how we're doing. Right now, if you look at, say, 9-5 in the East Pavilion, like I couldn't possibly tell you how they do with their response other than some anecdotes to patients clinically worsening. Why? Because I don't have a numerator or denominator for that. eCart will give that to you because you'll have the number of patients on that unit who crossed the threshold in a given week or month or year. Then you'll have outcomes, cardiac arrest, RRTs, and you'll actually know what the nurses did in response to all this. So now you can start to see if for this level risk, whether people are responding. Because the other problem is that actually the nurse may say something and then somebody says, I don't want an RT on my patient. I mean, there's so many ways that this can go wrong, but we start to get some insight into all these workflows. So that's one piece. And there's a lot of different data. I don't need to go all through, but the point is that you actually have data in how we respond. And we actually have a denominator because we have a tool that gives us the denominator now. And this allows us to sort of manage that. We're running a little late, so I'll skip some of these other things. So in summary, eCart provides an estimate of risk. It remains your job to assess and validate the risk. It does not tell you who should be the ICU or the floor. It is a reason to review the risk because it does have moderate positive predictive value. You should add it to your patient column for both consults and for the ICU and start to get a sense. Why? Because it's actually fairly predictive. Things we want to look at, and we're going to look at over the next 2 years, ED patients awaiting admission. Like there's no eyes on that. It's kind of a mess. Ryan knows, but anybody who's been down to the ED, they're scattered all over the place. And like, you know, there are doctors there, there are hospitalists, but it's hard to organize a large group of 80 people interspersed with another large group of sort of 80 people or 100 people.
Hard to care for 160 patients a day with 60 beds.
Right. Right. And they're in the hallway and they're all over the place. And now you actually have some way of taking a look at them without having to round on every single one of them. I think we've started looking at sort of ICU discharges, and again, it doesn't say if their score is elevated, they have to remain, but you can at least see why. If it's getting better, they're probably okay on the floor, but if they're getting worse, you probably should look at that. We're going to take a look at that data because we can. And then as we were rounding during the rollout, you know, the issue came up that person's score is really high. And they're like, they're not going to do very well. And it's like, yeah, so you have a choice, either do something about it or call palliative care or have a discussion. But the score, if you validate the score is correct, you should probably do something. So I was rounding sort of during the rollout, and I was on NP12, and there were 2 patients. So rather than starting and ending with the patient's story, one looked awful. I sort of peeked in. I was rounding for quality of care, and I'm not the consult. I wasn't the MICU attending. I wasn't going to say anything. So I just kind of watched this unfold with them looking at the scores, because this was sort of the first week. And one of the patients, the medical director was like, oh, and they actually went in and pushed some goals of care. The other one, the patient just sat there with lung cancer and worsening respiratory failure. And I was like, that score is like really high. Like they have a 1 in 2 chance of dying. And eventually they got it and sent the patient to the MICU, and they died in the MICU. But the point is, like, it was fairly predictive, and neither patient arrested, and both got somewhere. And so you can just see it happening. It's quite predictive. So anyway, that's it. We'll move on. But it's been a pretty exciting past couple of weeks with this. And I think it's our first real close-up counter with AI, and it's pretty useful. So thank you. I'm just going to take 2 questions, and then we'll go on. All right, Snigdha, run up here.
You partly alluded to my question in this last point about ED wards, because it looked like in the original University of Chicago study, they were talking about ward patients, like patients who were physically on the ward. So my question was, is it being rolled out to the ED borders? Because going back to the first slide that you started with, when we think about ICU mortality, and you emphasized how ICU mortality is vastly different for patients who come from the ED versus from the ward, are we taking into account that lag? And as we evaluate the before and after of eCart, how are we going to treat that ED to inpatient to ICU? Because I feel like it makes our mortality kind of look worse, and it would make it harder to analyze, to interpret the influence of eCart if that pool is not being accounted for.
Good question. It's actually very hard to interpret these interventions because there are several things going on. But that's true, because once you start looking at it, people's behavior changes. And it's going to be a little hard to know whether it's changes in mortality related to early transfer, more palliative care. I think one of the key things will be actually cardiac arrest, because it's definitely, that's part of the component. And that's why they looked at it. So in terms of the ED borders, it should apply to them. It's a little questionable because they're not getting exactly the same care as inpatients. But the team that did this thinks that it should be applicable, because when they look at the data, they're sort of collectively close enough. The issue is the workflow is different, and I have to figure that out with the ED, but I think it will be useful. Denyse?
My question is really a practical one. I'm anticipating we will have more ICU consults on the floor with this. Sort of what are the plans to help support the attendings, EPPs and stuff through that?
So far, it's not obviously led to a surge of referrals, right? Because not everybody needs to go, and some of them, you know, they were going to go anyway, right? So remember, this is also picking up the people who are going to go anyway, right? It's because sometimes the score goes up after the clinical recognition, right? Because you can't, in the data, it's hard to tease that out. So far it has not, and I haven't heard otherwise. I think the reason to talk about it is people are now saying, well, it's high, do they have to go or not? And the answer is no, it's still a clinical decision, because what it does is, unless they're CMO, it makes them get closer nursing care until there's sort of what's called a disposition. And that's actually another key part. I didn't get into the entire workflow because that's a little outside of purview, but they get more frequent vital signs until the nurse assesses them as a little better. And then they go back to their usual. So you get a little more data in that sort of window, which is really helpful, actually. All right. Ryan, last question.
I was just wondering, are we going to be incorporating this either in the background or forefront of implementation in the way we triage our patients to the ICU? Just because recently, clinically, if we have 6 to 10 admissions internally and externally through Y-axis pending, if we have access to this information, how much should we be allowing this eCart prior, like as we roll it out, to influence our decision to take a patient from PACU versus a patient from the ED versus floor versus Greenwich?
I think it's still going to be your clinical decision. If somebody's 99.9 on the E-cart, their risk is quite high, but it depends what is contributing to the score. If it's something that is addressable or not changing, their risk is lower, and you know that, right? I think the key point is that we don't lose track of sick patients. That's at the moment, that's the bigger problem, is that they kind of just disappear. And so I think if you're the night person, I can show people, you can have a list of everybody who's high in the hospital. You want to take a look at that. And that's actually a better way of thinking. Is there somebody else out there that I don't know about? I said that was the last question, but I can't say not enough Dolly in this thing.
But you could study this.
Yeah.
You could actually do the future Bayesian experiment in the system.
Yeah.
And see if it affects decision making.
So the lucky piece is the University of Chicago is very academic about this. I mean, they have some incentive because it's their product too, but they want to do this. So I think once we get our first rollout, there are a lot of projects we can do, and they're very savvy. All right, that's it. Dr. Lutchmansingh, you're going to close us out?
I'll be quick.
I already told the fellows now.
Yeah.
Sorry. I can't see my glasses. Presenter view. Yeah. Hit escape again. Escape. That one, sorry, I couldn't see it.
So as Jonathan mentioned, the post-COVID clinic is undergoing transitions. We still continue to see post-COVID patients, but we thought it'd be time for us to open up a post-ICU clinic, and we're going to use some of the resources we have from that clinic in this. So I'm going to briefly talk about complications associated with ICU survivorship, and then spend a little bit more of that time on the ICU clinic. So Lauren Ferrante and Asta gave really in-depth talks recently about the complications and complex issues associated with ICU survivorship. So I'm not going to spend too much time, particularly since we have very little time. But the idea of post-ICU care has existed since the 1960s. That was around the time ARDS was described. And so the initial studies were really interested in short-term outcomes and very pulmonary-based. As we all know now, particularly from work done by Margaret Herridge in the Toronto ARDS program, post-ICU complications is more than just a pulmonary problem. And so we talk about post-ARDS a lot in the pulmonary clinic because we are pulmonary doctors. And really and truly, some patients may have persistent radiological abnormalities. Some patients may have some persistent spirometric abnormalities, but usually this resolves. And if there's any changes that exist, there's reductions in diffusion capacity, which may or may not be clinically meaningful for those patients. What they found more was an issue was that patients had symptoms out of proportion to objective testing. PFTs were normal, but patients still reported significant limitations up to 5 years after initial hospitalizations. And most of those issues were really due to pulmonary wasting and muscle weakness. Patients can lose at least 18% of body mass at the time of hospitalization. And in the first week of critical illness, 2% muscle mass loss occurs each day. So you can see how this would be a problem at the time of discharge. And this led to the overall umbrella term of PICS, post-intensive care syndrome. PICS is defined in 3 domains, so physical, functional impairments, psychological impairments, and cognitive impairments. And it is new impairment in one or a combination of those domains or worsening of a pre-existing impairment, so worsening of cognitive impairment at the time of discharge. For patients who have issues with PICS, there is, as you can imagine, increasing disparities noticed in this patient population. Patients who are female, non-white, low socioeconomic status, or who have impairment in terms of other issues can be increased risk for PICS. And they also suffer in terms of services provided after hospitalization. So they tend to be the most vulnerable of the group. So Winchester decided, and with section leadership support, we thought that it was time that Yale had a post-ICU clinic. Post-ICU, the definition has been around for more than a decade. And so it was time for us to start focusing on the patients we took care of in the ICU because care didn't end at the time of discharge. For Winchester, because we're a fledgling clinic, we're in the process of doing a lot of figuring out. And so while I present the criteria right now, I expect this may or may not change over the next year. But for right now, we do require patients to have some form of respiratory failure to be referred to us in the clinic, and they need to be hospitalized for at least 72 hours. The patients do not necessarily have to belong to the ICU. They can be patients in the step down, for example, but they should have some form of respiratory support that was required. Either they required high flow oxygen supplementation, non-invasive ventilation supplementation, or they were intubated and ventilated. Couple obvious things, but I like to state that patients we do not want referred to us would be patients who are planned for CMO, who have do not hospitalize orders in, or already established with another pulmonologist. We're not planning to take the place of another pulmonologist. So whether they're established within Winchester or outside of Winchester, they don't necessarily need to be referred to us. I present this particular workflow for the clinic. There's a couple points that are being worked on, and I'll point that out. But the general idea is to utilize the multidisciplinary clinic that we have in place already. We are looking at patient-related outcomes. So that would be the HADS and EQ5D. On the day of testing, we are a pulmonary clinic. The patients have a history of respiratory failure, so they will get pulmonary function testing. But largely, what we really want to get out of these visits is the MD visit and the physical therapy evaluation. So for those of you who may not know, we have a physical therapist attached to Winchester. Kathy Reeves is the physical therapist who's been with us throughout the post-COVID clinic and will continue with us with the post-ICU clinic. And she does not only the physical function evaluation, she will also be helping us with the neurocognitive evaluation. Our tool of choice is going to be the MOCA. In addition to that, we are hiring a new social worker at the end of February, and she will be incorporated in the clinic flow. The idea at this point in time is to have her as an opt-out option rather than opt-in, meaning everybody gets a mandatory social work evaluation unless they say they really want no part of that. The pharmacy medical reconciliation part is sort of my wish list part of the clinic. As everyone knows, patients can often get discharged from the hospital with multiple medications that are not accurate. They were added on during hospitalization. They don't necessarily need it. The pharmacy part of it is part of my wish list part, but is not built into the flow as of right now. And then depending on what we expect from patients, we'll determine needs for frequency. One of the things that I do love about the post-ICU clinic is I think there's an opportunity for patients to improve and get better and graduate in clinic. I think sometimes those of us who take care of chronic lung patients, that can be a little challenging because patients go the other way, they deteriorate. So I think there's a lot of promise to serve the patients here and help them improve. So this is the part I need all of your help with, how to get the patients into the clinic. And so it's still a pulmonary referral. All you need to do is put post-ICU in that referral. The question about when to refer the patient is still sort of in flux. Right now, we've been taking patients at the time of discharge. If you see patients on pulmonary consults, for example, and you'd like to send them to us, that would be an appropriate time. There's been questions about whether or not referring them at the time they leave the ICU is appropriate. And I think most of you may be familiar with the ICU pause that the residents fill out at the time of transfer. There is a part of that that's built in, and Shioko's working on it to suggest if a patient can be referred to the post-ICU clinic. If you do think someone has a reasonable chance of leaving the hospital, and you think they would benefit from going to the post-ICU clinic at the time of discharge, it would be reasonable to place the referral at the time of MICU transfer. I'm doing a lot of work with our referrals team and how to get these patients in appropriately. So I encourage you to think about it. If you know the patient has been to the MICU for the third time in 3 months, it is probably unlikely that they will leave the hospital. So that would not be the person to place a referral for at that time. Then sort of kind of last parts of it. One of the things that I think is really important, particularly in the outpatient setting, is also to build relationships with other clinics. When we started the post-COVID clinic, one of the struggles was that we really didn't know what to expect from patients. And in the post-ICU space, we actually have the benefit of multiple ICU clinics in different areas. Lauren Ferrante and I are members of a group that's known as CAIRO, the Critical and Acute Illness Recovery Organization. It was born out of a group that started in SCCM, and it is consisting of the post-ICU clinics from Vanderbilt, Michigan, Oregon, Cleveland Clinic. And part of the reason we joined this program was not only to be able to utilize them and their expertise from a clinical building perspective, but they also have published papers in the past looking at different post-ICU groups across the United States. So there is a lot of opportunity here for scholarly activity too. So lastly, just to remind you that ICU survivorship is associated with high morbidity. At the time of discharge, most patients report at least 80% of patients will report symptoms consistent with PICS. 1 year after hospitalization, more than 50% of patients can report symptoms consistent with PICS. And so if you do think a patient would benefit from the facilities at Winchester, if they have been hospitalized with respiratory failure for more than 72 hours, please consider referring them to the post-ICU clinic.
Thank you, Denyse. Any questions? All right. Thank you, everybody. Have a good afternoon.